oh, sorry. I'm very pleased to introduce Dr. Sarah Danzo, who is an assistant professor in our Division of Child Psychiatry here at the University of Washington. And Dr. Danzo brings deep expertise into integrated behavioral health and youth suicide prevention work. Dr. Danzo was trained at Case Western Reserve University and further specialized through her residency and fellowship at the University of Washington. And her work centers on strengthening the caregiver adolescent collaboration, improving crisis care pathways, and advancing evidence-based approaches to suicide risk reduction, particularly in primary care settings. Dr. Danzo has contributed to both clinical program development and advanced the scientific basis for providing high quality and implementable suicide prevention programs as she blends research, clinical innovation, and community partnership to support youth and families navigating suicidal crises. Her scholarship continues to shape the field through impactful studies on caregiver attitudes, primary care integration, and the long-term developmental trajectories of risk and resilience. With that, we're super excited to hear about Dr. Danzo's NIMH-funded K23 award and review the role of primary care in suicide prevention, particularly for adolescents and early preventative disclosures. With that really brief introduction, I'm going to hand it over to you, Sarah. Looking forward to your talk today. Thank you.
Thanks, Molly. That was very kind. So let me try getting these slides up again. Okay, can folks see the slides? Okay, perfect. So as Molly mentioned, I am a psychologist over at Seattle Children's, and I also am an assistant professor at University of Washington. And a lot of my work these days focuses on building more effective and acceptable suicide prevention kind of pathways, specifically within primary care and integrated health settings, getting perspectives from kids, caregivers, and providers on how to actually build those. And so that's what I'm going to be talking to you about today. No conflicts of interest. This work was funded by an NIMH K23 award. Everything I present is my own views and not by the NIH. And today, the first objective I want to go through is just reviewing suicide risk during adolescence and the role of pediatric primary care specifically in suicide prevention. That said, everyone here knows a lot about this, so I'm going to go through that pretty briefly. So from there, I'll go through some of the findings from this project and specifically looking at some of the barriers, facilitators, and needs that we've uncovered from primary care staff, adolescent patients, and their caregivers regarding the current suicide prevention practices that are in place within this setting, and then also how we use that information to co-design with these different users and adapted training guidelines, as well as intervention content for these settings. So some brief background, as many of you know, suicide is a leading cause of death among 10 to 34-year-olds in the United States. 1 in 5 U.S. high school students have seriously considered attempting suicide in 2023, and suicide rates have continued to rise among preteens. And that's all just to say that there's more youth mental health need than there is services that exist. And so there's a dire need to increase access to effective and acceptable suicide prevention services. And one area that has been getting increased attention is pediatric primary care to be able to do this. This is for a couple different reasons, but first, about 50% of youth who die by suicide contact a primary care clinician within the month prior. This has contributed to updated American Academy of Pediatrics guidelines, which now recommend at least annual suicide risk screening for youth ages 12 years and over, even if there's no risk factors that are endorsed previously. This is great in a lot of ways. It's increased identification of suicide risk. However, primary care staff have varying levels of training and comfort in actually being able to respond once they've identified suicide risk, meaning that a lot of times youth who have been identified in primary care with any level of suicide risk, even if it's passive, are being sent to the emergency department, and often in the end kicked right back to primary care when they're not admitted. So the goal of this project was really to try to address this concern, reduce unnecessary ED referrals, and help primary care develop feasible and acceptable pathways where they'd be able to actually be able to kind of start the stepped care pathway of being able to manage some of this risk. The first thing we did to do this, we use a user-centered design approach and specifically the Discover Design Build Test framework to do this. So the steps laid out here are all of the steps of this project. The ones with our green check mark are the ones that are completed and that we're going to be talking about today. But the first part was completing contextual inquiry and needs assessments guided by the Consolidated Framework for Implementation Research with 3 different clinics. And specifically for this project, we wanted to look at different geographic settings. So partnering with clinics in urban, suburban, and rural Western Washington state. Following that, we used our information that we gathered from that first step to then co-design initial prototypes of training and intervention materials for user testing. We then went through 3 rounds of iterative user testing and refinement, which has led to the final intervention package and associated training materials, which I'll show a little bit of today as well. We are currently in the pilot testing phase, but I do not have results to share on pilot testing with you at this point. Happy to show those once we're done. So for this first part, our needs assessment and contextual inquiry, we recruited participants, including adolescent patients between the ages of 10 to 18 years old with current or recent suicidality, who saw a primary care provider at least yearly and were not in a current suicide crisis, meaning that they were not in need of going to an emergency department or needing acute care. Caregivers of eligible patients were also eligible to participate, and primary care staff who worked with pediatric patients and spoke English were also eligible. For this study, it was restricted to English speaking just because of kind of capacities of the project itself. Goal for future is to be able to expand this out. But for this project, it is all English speaking participants. We recruited folks from 3 different geographic settings by sharing recruitment flyers with clinic champions who then shared them with patients, caregivers, and other providers. Within that recruitment flyer, it had kind of a QR code interest and eligibility survey that interested folks filled out. We screened for eligibility, and then we used a purposive sampling approach to get a purposive sample across these three clinics. So the first step we conducted, and this was now in 2023, I think, 2023, 2024. We did contextual inquiry with our 3 clinics, meaning that we did a day of observation in each participating clinic, both to understand kind of the inner and outer context, what kind of were their workflows, how did it work, how busy was it, what were the times of day that things changed, and really kind of were just flies on the wall for that day in each clinic. Our clinics, I should mention, were located in Centralia, Washington, which is a really rural clinic down by Mount Rainier area, Olympia, and then Mountain Lake Terrace. So kind of those 3 different areas. We, following contextual inquiry, conducted semi-structured interviews with 20 teens, 16 caregivers, and 18 primary care staff, guided by CFIR, and it was really focused on understanding participant perspectives and experiences of current suicide care and primary care. And then following that, we got some self-report questionnaires from all of our groups. So everyone completed demographics questionnaires for some background info. Our adolescents also completed mental health screeners, including suicide risk, anxiety, depression, functional impairment. And then our caregivers and our teens also reported on parent-child caregiver relationships. Analyses for this part are, we conducted our descriptive stats and SPSS. Interviews were audio recorded and transcribed. We developed an initial code book based on CFIR, and then used thematic analysis and deduce. Our thematic analysis looked at differences and similarities across each user group, so our providers, youth, and caregivers, and then also looked at differences and similarities across geographic contexts before using a task function mapping approach to map our needs onto the design requirements for the intervention. So I'm going to show a lot of our qualitative results from this piece, but the first thing I want to kind of highlight is that our themes were actually really similar across our geographic settings, which we were not anticipating. Our themes across user groups were different, and we'll go through each of those themes independently per group. But despite the perceptions of things being pretty similar across settings, the contexts were actually really, really different. And so I want to show a little bit about how those were different. The only main difference that emerged in perceptions across our clinics was regarding the implementation of universal suicide risk screening. So our providers at our 3 different clinics felt pretty differently about this. One clinic in particular was really anti-universal suicide risk screening. They didn't want to do it. They had a lot of hesitation. And then our other two clinics were pro-suicide risk screening, but differed in what age it should start at and what measures they wanted to use. So again, just kind of slight differences in how people felt about that. But in terms of difference in contextual factors, our urban and suburban clinic settings chunked together a little bit. They both had access to similar number of community mental health resources. They were generally accessible via public transit. They had stronger relationships with nearby hospital systems. They had an option for telehealth. However, they did not have any access to warm handoff availability from IBH providers. And they reported that same or even next day appointments, if somebody needed something urgently, were really difficult to do. That said, they talked a lot about concerns about rising rates of suicidality within their clinics. But when asked if anyone had recently died by suicide, both clinics reported that within the past 2 years, none of their patients, to their knowledge, had died by suicide. Our rural clinic setting had access to the lowest number of in-person community mental health resources. That was also paired with telehealth for them, had a lot of difficulty. They talked a lot about difficulties with Wi-Fi and internet connectivity. So just a lot of troubles with accessing telehealth for families. An interesting thing that came up was patients and families often talked about running into their providers in community settings like the grocery store, which then we'll see as we get into participant perceptions led into participants talking about concerns about stigma and confidentiality. Our rural clinic also had a lot of firearm access, and that came up a lot from all of our user groups, and difficulty knowing kind of how to manage that. On the flip side of all of these struggles, though, they actually had the most flexibility with warm handoffs and scheduling after hours and urgent appointments. And this was in part a response to this clinic had reported several patients dying by suicide in the past 3 years when we asked, and two within the previous fall. So they, at that point in time, were really trying to up their suicide prevention practices and were really motivated to do this. So moving to perceptions. So for our providers, they reported several challenges, and this is across the clinics. One thing that came up over and over again was mental health stigma, making mental health conversations really challenging. Providers also talked about increasing frequency of suicidality coming up, along with time constraints to address this. So they often talked about having 15 to 20-minute sessions and being really capped at that time limit. Providers also talked about a lack of confidence in knowing how to address suicidality when it came up, difficulty knowing how to navigate patient confidentiality, especially for teens and younger kiddos when they don't want parents involved. And often across all clinics, even the ones that were more accessible, often talked about insufficient community mental health resources. So feeling like if they made a referral, there was no promise that that kid was going to get connected. They also talked about concerns about screeners. So they talked kind of about this double-edged sword of if they sent them in advance and somebody endorsed safety risk when they're not in the clinic, then it was unclear what they needed or how they could respond. On the flip side, there was confidentiality concerns if they gave these screeners in the waiting room or if kids had other people, including parents around them, who might actually fill out the screeners for them. So a couple quotes from our providers around challenges. It's always a tough visit. It completely derails your day, and this is happening to us almost every week now. There's a fear having these conversations and what to do and where do I go next. We can't manage the onslaught of referrals for IBH and suicidal ideation, and we don't have after hours, we don't have weekends, we don't have crisis teams. I feel like it's daily that I'm working. It's at least some sort of, I'm having thoughts. There's a lot of passive suicidal thoughts, or I would feel better if I didn't have to deal with this type of thoughts. And I don't think I've been trained in the safety plan. I'm struggling. I worry. I'm not confident. So lots of overall challenges for our providers. For teens, they actually reported they felt comfortable discussing suicide risk with their doctors, but over half reported they don't respond honestly when they're asked. When we dug into this a little bit more, teens reported not being honest on screeners due to stigma, fear of hospitalization, fear of parents being notified, overall not understanding confidentiality, and this general idea of like, even if I tell you, you're not going to be able to get me help, so lack of available services. Teens were really, really, really clear. They do not want parents involved. And they also talked a lot about that providers taking notes while they talk to them about mental health and suicidality is a big turnoff that makes them not want to open up. So some quotes we have from our teens. The screeners feels okay, but it also depends on how many people are in the waiting room. If you're super crammed and you're by someone, I really wouldn't want anyone to see that. When I'm with the doctor, they're there the whole time typing on the computer as I'm talking to them. And I think it adds a lot of like, oh my gosh, what if this gets out to other people? Or like, why are they documenting this? They said they, meaning the doctor, just say it in a monotone way just to say it. If they're going to ask you and talk to you about it, I feel like they need to actually care and not just say it as a way to move on to the next question or to say that they said it. The questions are usually yes, no answers or not likely at all to always, and that's a very weird scale. And that's referring to the self-report screeners. And then around stigma, one shared, I think it's just this idea that suicide is this big, scary thing. And it's really scary to talk about. It's really hard to talk about. And it's kind of hushed. The stigma around it makes it hard to want to reach out. It makes it hard when someone reaches out to you. So overall, just really hard to talk about this. On the caregiver end, they talked about not having enough tangible resources or education for themselves or their teens around mental health. They talked about often they're not brought in until, someone's really, really concerned about someone's safety, and that then they're given lists that are really overwhelming of all the different places they need to call to get their kid help. They talk about not having enough support for parents while they're waiting for services. And they also talked a lot about feeling like safety planning is overused, and we'll get into that in a little bit as well. Caregivers also highlighted that there's a lack of communication between PCPs, schools, and other mental health providers, and that felt really frustrating, especially when their kids are at school every day. And similar to our other two groups, also talked about stigma reducing the likelihood to talk about mental health or suicide risk concerns with their child's doctor. So caregivers shared, you feel isolated in the beginning. There's an emotional cycle that you go through. I'm embarrassed this is happening. I'm scared this is happening. And then you go back to, I'm mad again. I think those feelings need to be addressed. Another shared, it took like maybe 17 articles for me to find like you need to hide bleach and stuff. I would have never known. So, going over things like that you wouldn't think of because you don't think of everything. Around stigma, one shared, there's also just a huge stigma to it. I'm like, but now these people, are they going to look at my child different? Just always trying to figure out what's better. Is it to put it all out there and be like, hey, this exists? Or to really protect my child so I'm not putting a stigma on him? And I just want to call it, this one was really powerful to us, and that this parent was really talking about protecting their child by not sharing the concerns because of the concern about stigma. And that was something that came up a lot amongst our parents. And then the last one here, the other challenging piece is that parents are calling so many places for all of these referrals, and it's a waiting game, and we weren't getting help fast enough. There's just not enough, I guess, places to go to help you and your family get through this. So overall, we had a lot of challenges across all of our user groups, but there were also several facilitators, and I think these are worth calling out because it does speak to the motivation of all of these groups to actually want to implement something within the setting. For providers, they talked about having integrated behavioral health overall, as well as the ability to do any warm handoffs was really astronomical. It was super helpful. They talked about the ability to schedule urgent or next day appointments was also useful. One clinic had just implemented extended time for adolescent well visits, where adolescent well visits in particular were 40 minutes instead of 20. And that was a really big facilitator for that clinic. They talked about having screener and workflow tools embedded in the medical record system was helpful, and having front desk staff administer screeners to patients in the waiting room was also helpful to reduce time. So one quote we got from providers was, having an IBH provider in this clinic is just astronomical. It's such a resource. Families love it, and having a one-stop shop for both, it's convenient. Kids don't have to explain that they're going somewhere different. They're coming to the pediatric office. It's normalizing the visit. It's normalizing the approach to behavioral health for kids and teens. The results speak for themselves, and the parent comments and everything coming out of the program and how beneficial it was is just huge. Teens again shared that they think being asked about suicide risk is important in primary care, and that they feel comfortable being asked about it and have established relationships with their doctors that enhance that trust and comfort. But again, want to highlight the challenge with it was they do not like how they're being asked about it, and that is a holdup in how they're responding honestly. Similar to teens, caregivers also talked about trusting their kids' PCPs. They generally felt comfortable with their kid's doctor asking their kid about mental health and suicide risk, and overall felt comfortable with their child talking to the doctor alone. One parent shared, I think there's nothing wrong in asking because, in my opinion, it can only help. If they aren't comfortable talking about it, there's no harm more than not having asked at all. And if it can help one person or one person gives off a vibe that they get a sense that there might have been something, if it helps one person, it's worth it. So a lot of work then went into kind of mapping all of these different challenges facilitators needs into the design requirements. But generally what we found for our design requirements here was for providers, they want access to additional behavioral health staff and more team-based approaches. We, for this project, obviously couldn't create new behavioral health staff, but we were able to develop training systems to be able to build more team-based approaches that can allow more people to function within the setting. In line with that, they wanted more training for position-specific roles, as well as an all-clinic staff training. They wanted standardized workflows and resources that can be built right into the EMR. They wanted more strategies to reduce stigma, more targeted resources to give teens and parents, and better referral pathways and opportunities for urgent follow-up. The other thing they noted was wanting stronger relationships with schools and community mental health clinics, feeling like, yes, they're able to kind of start this process, but if they could really partner with somebody else in one of these other settings that kids are often going to, that would be really useful. For teens talked a lot about they want more holistic screening and assessment processes. They talked about wanting more validating responses from providers, needing private spaces to complete screeners and talk about suicide risk. Our teens and parents also introduced this idea of wanting more universal prevention resources, wanting resources, handouts, things that are given to everyone to reduce stigma and make it feel less targeted. Teens also, interestingly, while they talked about not wanting parents involved, they did want more psychoed for parents. They wanted doctors to talk more to their parents up front, even when there wasn't any concerns, to reduce any possible negative or harmful parent responses that often led to kids not wanting to disclose risk. But again, want to highlight, they also want more autonomy and less parent involvement overall, unless risk is really acute. And they did highlight, while they still don't love parent involvement if risk is acute, that they acknowledge parents are needed at that point. Similar to PCPs, they also want their PCPs to connect to schools to support them. And then caregivers, in contrast to kids, want more information. They want to be included in their child's suicide care. They want to know why their child is being asked about mental health and suicide risk. They also want more resources and support for themselves. And while they're getting those long resource lists of where to connect, they actually appreciate getting those, but want them to feel more useful and less overwhelming in the format they're given. They want to be more informed on what out of all of those options are what they really should be following up with. And they also want providers to have some follow up with them and not just their kids, to be able to loop in the parents and kind of support them as well. And then finally, similar to our PCPs and kids, they also want PCPs to collaborate with schools more, as well as any other community mental health services. So that was kind of the summary of our AIM 1 findings. This then led to our second AIM, where we met with adolescents, caregivers, and primary care staff, and largely different groups of folks, although our primary care staff had overlap with our AIM 1, to co-design and then iteratively refine and user test a series of training and intervention materials. So our recruitment and inclusion was the same as AIM 1. Participants this time included 16 adolescents, 14 caregivers, and 27 primary care staff. The reason we wound up with so many extra primary care staff was they were our group that we had the most iterations with to refine our training and kind of our workflow materials before we were able to meet acceptability and usability. So what I'm going to show next, I'm going to kind of work backwards. So the results of this AIM are final usability, acceptability results from our final iteration of our user testing were surprisingly high. Acceptability, we had 98% overall acceptability of the final intervention and training materials, 95% feasibility, 96% appropriateness, 90% usability. Our target was 80%, so this far exceeded what we were going for. I do want to acknowledge our caregivers had the highest acceptability, like had the highest everything. We are hypothesizing that's just because there was extra parent content in the intervention materials that we developed. Our teens had the lowest at, some numbers in the 80s, although high 80s overall. And I think some of this also comes from we had more parent content and we did not go with all of their desires to totally get rid of parent involvement. So I'm going to walk through some of these updates. How I'm going to think about it is we have some screenshots of the materials that I'm going to show you as we go. We have created both handouts and website content to be able to be accessed in both capacities, as we got a lot of feedback from kids and parents on they often feel overwhelmed when they're getting these materials in session. Sometimes they forget them, sometimes they throw them out, sometimes they just get lost, in the day to day. And so a lot of folks wanted the ability to have information that could be viewed on a website as well. Docs also wanted this so that they could kind of go through things online with kids and parents in the session, and then they could send them the handouts later. So I'll show you the handouts generally, and then we'll walk a little bit through the website. What I show, I do want to acknowledge is still a prototype. We are still testing it. So while, the website is live for user testing and for piloting, it's not live for general public at this point. So first, I want to talk about how we updated our provider training. And this was actually the hardest thing for us to update. I think it took the most back and forth with figuring out how we could do this in a feasible way for folks. So first, they wanted more standardized training workflows and guides for different providers and staff types. So this meant creating these different pathways for nurses, PCPs, MAs, IBH, even front desk staff, and being able to come up with ways for both clinical and non-clinical staff, how they might be able to fit into this pathway and what would be appropriate. And that was different for each of our clinics. The other really big piece that took us a bit of time to figure out how we would feasibly do is they want briefer training modules that build off of each other instead of a longer all-day training, for example. So they don't want, and this was across our clinics, they don't want a 2-hour training. They don't think that they're going to be able to do a 2-hour training and then go use it. Instead, they talked a lot about getting a little bit up front, having something asynchronous, then do some in person, then let them try what they've learned so far, then come back and do a little bit more in person, then let them try more, with the idea that they would be able to then kind of master those smaller chunks before moving on to implementing the rest of the pathway. So we have developed this. We have not done it yet in real life. We're going to have that go live next month and we'll see how that goes. But that is overall what our feedback was on training. The other big piece that we hadn't considered previously was they really wanted their IBH team to be involved in the training so that their clinic kind of owns it along with our research team. And to identify IBH or clinic champions who can be intervention super users. So someone that when we do the training, we go through extra with this individual who they then can be the person that the primary care team accesses to consult with if anything comes up throughout the time that they're using it. So moving into our materials, to respond to this more holistic screening piece, kids talked a lot about, they get asked so many things about what's not going on in their life, and that makes them not really want to talk about it. So first, I guess working backwards on this, kids talked a lot about wanting fidgets. We're asking them stressful questions. We're asking them to talk about things that are hard and that they haven't necessarily talked about before. They talked a lot about just having something to hold, squeeze, play with, fiddle with as they're answering these questions could go a long way. So one thing we did is we now have fidgets for all of our clinics that are given along with our screeners. But the other big piece is they wanted something that focuses on positives and strengths. And this ties in with how we're thinking about assessing risk and protective factors as well. So we developed this identifying strengths worksheet. This is adapted from the safety acute protocol from Jonas Arno's group. That was, they have this identifying strengths component within the intervention if a kid does have suicide risk. We've adapted it from a conversation to a paper form and to a screener instead of a conversation. So the idea here is that along with the mental health and suicide risk screeners, kids would get this paper screener that asks them to identify just three strengths or things they like about themselves. And they could write them in at the bottom if none of these feel relevant to them. And then at the bottom, it asks some open-ended questions about anything that they want to discuss with their doctor, any trouble or things going on with school or friends, anything tough and anything that they are proud of or want to talk about. And the idea, again, is just to kind of be able for them to focus on something more positive and then for the provider to be able to review this and have more in-depth conversation about it. I do want to highlight, we are not asking providers to put this in the medical record. We are allowing them to send the kids home with this if they want it. We've gotten some kids who said it's pretty and they want to keep it. So this is just kind of more to guide conversation. Other big things we did is we created some universal prevention materials. So this is a lot of handouts that get sent in advance or are given up front at the clinic waiting room. I'll show you what some of these look like. It's a lot of information for both teens and parents about what to expect at adolescent primary care visits. They already get some of this for medical visits and kind of like billing and things like that. So this just adds on to that. And then some universal prevention on mental health and suicide risk psychoed for teens and parents, really framed again around as your kids move into teenage years, these are some things to look out for. And then we created some lethal means restriction handouts for everyone. So we call it safety proofing your home. And we will talk a little bit more about this, but having kind of lethal means that is for a crisis, and then general guidelines around restricting access to certain things, even if your kid is not in a crisis. So I acknowledge this is probably pretty small for most of you on a computer screen. I'm happy to share some of these as we go. The reason I'm not sharing the really big versions of this right now is just because we're still user testing them. But these are 3 different universal prevention materials for teens. On the top right, you see this like Safe Teens little thing. This is actually a business card. Providers and kids asked for us to have some sort of business card with the website info on it so that kids could take it, put in a wallet, put it in the back of a phone case, somewhere that they don't have to necessarily talk about it with parents, but also somewhere that they won't lose it. This other information, though, so what to expect at your doctor's office, is trying to use destigmatizing and more normalizing language. So at the top phrases, as you get older, your doctor will start to ask you about mental health at your yearly checkups. Mental health includes how you think, feel, and act. Then it goes into a little bit about why do we talk about mental health? What does asking about mental health involved? It goes into when would parents be told? What is privacy? How does that work? And there's information both for over and under 13. And then at the bottom, there's information that you can't actually see, but that would have the website information and a QR code if they wanted to go access the website for more information. For starting the conversation about mental health care, again, try to use destigmatizing language. So we have if you want to talk to a family member or friend about starting therapy for yourself or seeking mental health support for them, here are a few tips to start the conversation. And then on the right, we have this guide to navigating mental health. And this one goes through a couple different pieces. It goes through how you can take care of yourself if things do start to get tough, how to know if you need help, who you could talk to if you're not ready to talk to a parent. And then what teens were really focused on adding, and providers were actually very in favor of it, was what if my friend needs help? We got a lot of feedback from kids that they're more likely to tell a friend than a doctor. And also when they are told by a friend that it's really overwhelming and they don't know what to do. So having a little bit of info there to help normalize that they can bring that up with adults too. Caregivers got similar information on the what to expect in supporting your child as they grow, but they also get information on how to support your child at school, which just kind of talks about partnering with school as an important piece of kind of overall well-being and gives example language of if a parent did want support from school, what they could say to request either services or to meet with somebody to learn what services are available. And then our safety proofing for everyone. We framed this as so at the top, we have this little blurb. When your child was younger, you kept them safe by baby proofing your home. As they get older, you can keep them safe by updating your safety proofing for your growing child. And really, what this is focused on, since everyone who's getting these mental health and suicide risk screeners would be getting this, is focused on supporting open communication, being careful with guns. And we went back and forth a lot about the term firearms versus guns, but overwhelmingly, we're told to use the word guns. And really framed this not just as keeping your child safe, but keeping your child's friends safe. That if other kids come in, you don't know what they're doing, where their head's at. So making sure that guns are stored away from all kids. And then limiting access to drugs, alcohol, and meds. The big call out I want to call out here is we generally on the guidance for everyone is just not having really big, Costco level size bottles of things if you don't need it. But the other thing that especially our rural clinic brought up was needing to call out families having Narcan or naloxone. So being able to address concerns about opioid and narcotic use and having families be aware of Narcan, naloxone, and being able to have that in the house in case of an emergency. So those are universal updates. Safety plan updates also got a lot of updates. We did not change the overall content from essentially a Stanley Brown safety plan. However, we changed our wording, phrasing, and a little bit of the content. The largest feedback we got from teens was don't call it a safety plan. I do want to acknowledge half of our teen participants had a prior suicide attempt, and so a lot of them have gone through lots of different versions of safety planning. And so that probably played a role in this. Other things we did is we created different versions for different risk levels. This was both to accommodate time concerns within the clinic, as well as just kids kind of giving feedback that when they're asked to do all of these different things, it feels like it doesn't apply and they don't take it seriously. We created multiple formats with different examples, fill in the blank, and options to choose from. And I will show you what that looks like. But that was in response to kids saying it's really hard to think about ideas on the spot, and providers saying, I really don't have time to spend 40 minutes trying to come up with ideas of what a warning sign might be. We then associated a 1, 2, 3 year red, yellow, green communication system that parents and caregivers can use with kids to be able to do, like, communicate about safety. And then we added a school counselor as a support professional. So lots of kind of details, but generally what this wound up looking like. Um, this is our safety plan for passive SI. It is not really a safety plan. We're calling it planning for tough times. And as you can see, it only includes what we're calling a 1 or a 2. So when things are okay is a 1, and 2 is when they're starting to have thoughts of self-harm or suicide, but feel pretty confident they can keep themselves safe. But just general, what are situations that get them there? The big add here is reactions. So what happens when they feel this way? And then what can they do to cope, and what adults or other people can they go to for support or distraction? On the back side of this, it goes through professionals they can contact. As you can see, we did add the school counselor as well as Seattle Children's Psych Urgent Care. And then instead of saying like reasons for living, kids were pretty specific that they actually want to be asked about what brings you joy or makes life meaningful. And so we update our language here. And this is obviously a shorter one. We're coaching providers to introduce this if a kid has passive SI, and that they can start filling it out and then review it at the next follow-up appointment that we would ask them to schedule within 2 weeks. This is our full safety plan, renamed Getting Through the Moment. This is a lot more complicated, obviously, but it's really the first two buckets. This 1 and 2 is the same as our kind of abbreviated version. The 3 is if a kid is in crisis, if they really need support to stay safe. And the big updates here is trust adults, they can ask for help, what they can do that's helpful, and then what might they do that's unhelpful. So calling out not just who they can go to, but like having something written down on paper of what people do that's helpful and unhelpful. The other big update to this is starting with a check-in. So before even going through the actual safety plan components, having kids check in with themselves about kind of a body scan. So how does your body feel? Are you hungry? You're tired? Have you moved? Are you sick or in pain? And just a quick reminder that sometimes taking care of those basic body needs can go a long way in helping you mentally feel better as well. On the back, we again have the reasons for living, but really talking more about bringing joy, making life meaningful. We also, for what can you do to make your home safer, we have what you always have of what might be dangerous and what should be removed, but we added what could be helpful and should be added to the home. So kids talked about, sometimes you just want a fuzzy blanket or fidgets, or you need like a place to work out. So we added not just what can you take away, because kids talked a lot about how that can feel really negative, but also what can be added to make it safer. This is the version kids would get. However, there's also this version, which on your screen probably looks really little and hard to read. This is the exact same thing that providers would have that has examples of everything that can go in these boxes. They are not all inclusive. There's other things that people could come up with, I'm sure, but are examples that they could pull out to be able to help facilitate conversation. Some examples, in case it's too small to read, on our level 1 over here, example of situations might be like drawing, playing music, watching a movie. Reactions might be something like you're sleeping well, being active, feeling energetic. For 2 examples of situations that might help, that might get you to like having some suicidal thoughts, but ones that you can manage, might be not sleeping well, having hard homework at school that you don't know that you're going to be able to complete, not doing well on a test. Examples of reactions might be pacing, yelling, talking less, whole list of different coping skills that people can choose from. We did get a lot of feedback from kids on what should go there. A lot of feedback on what the kids would say are triggering to hear if they get told to, take deep breaths. So overall, just lots of examples here. On the back page, we have this communication about safety that parents and kids would go through if there's active suicidality, and parents then get a version of this as well. So the parents, in addition to seeing their child safety plan, would also get this kind of fact sheet of how can parents support children who are having suicidal thoughts, along with just some general things that typically parents do that are helpful or unhelpful, with the idea that kids and parents with the doc can go through this together, cross things off that are irrelevant, add things that are, but have some general guidance. And parents gave a lot of feedback that this was helpful because sometimes if a kid said that they asked too many questions, they'd get mad about it. But if they just see on a piece of paper that that sometimes is unhelpful, that they're like, oh yeah, like I also don't like it when people ask me lots of questions. Lethal means, like I mentioned, we just created two versions. There's the targeted intervention, which not any huge updates to, but we are calling it safety proofing for a crisis. The lethal means language was just overwhelming to some families, and a lot of parents talked about how they understand the word safety proofing. And then again, the universal that we already went through. Another big update was we added a lot of parent support resources, both in terms of supporting their child, but along with supporting themselves as well. There are handouts for this. I didn't put them on here because I'm going to actually show you what they look like a little bit on the website. But we included information on parent caregiver support groups and really focused on ones that are free and can be accessed nationally. Some different tools for self-care, and then parents and kids also talked about wanting to hear other people's stories, wanting it to feel like they're not alone, being able to kind of link up with what are other people going through. The other thing that I'm going to show you on the website and not right here is how we've tried to update our mental health navigation and resource guidance. The big things we've done here is there's crisis lines, but we also call that non-crisis support lines or warm lines. We provided information on different levels of care and how to access them, tips for finding a therapist and how to understand referral services and directories. And then we spent a lot of time with family advocates and case managers on how to streamline some of the resource lists, and then did a lot of user testing with kids and families on making sure that that felt easy to navigate. So again, these are all handouts, but these two components are actually more useful on the website. This is a screenshot of the website, and I will show you the actual website in a second. But this is the homepage for it. Again, that Safe Teens business card at the bottom. The QR code on it is on the back of the business card and would take you right here. And let me see if I'm organized enough to do this. Are you seeing a website? Perfect. Okay. So this is the actual website. I'm going to click through it a little bit. This is the homepage, like I said, at the doctor's office. Goes through a lot of those universal prevention materials to kind of figure out, yeah, if you're a kid or a teen or a parent, you get to choose, and then it will go through all of the different pieces that we just showed on the handouts. So how can I get help? What about privacy? Then there's intervention materials. So you have kids and teens, and it goes through what should I know about mental health, self-care and coping, how to talk to adults, supporting a friend, and hear other people's stories. Hear other people's stories just feels like the most novel thing we didn't actually show in the PowerPoint. So I'll go through a little is kind of just different videos that we've vetted from different people's perspectives of what they've gone through with mental health. All are coming out the other side of it. We've tried to do it from like a representative group of people. We have from It's Gets Better Project. We've got videos as well. And then some kids talked about videos are really great. Sometimes they also just want to read. And so being able to do this. Our male identifying participants also talked about wanting male representation, and that, it's okay to have a celebrity, but it'd be really nice if they had like an athlete's perspective of getting through it. So we have Kevin Love for anyone who's a basketball fan. And we did the same thing for parents. So parents, we have this parent guardian support groups, which goes right to different resources they can access. These all go to the actual organization link, but also has very clear, just like how can you call, how can you access them right from here. It has different resources where you can actually access. We have Just for Dads groups from feedback that a lot of things are focused on moms in particular. And then we did include information for LGBTQ families as well and trans families. We got a lot of feedback from certain clinics that this might be looked at negatively, but we overall decided we're going to trial it and see how it goes. Um, Parents also have hear other people's stories, so they have something similar in terms of podcasts. And we did user test all of these different pieces, removing stigma and what like they needed to know from other people's perspectives. And then our last thing I wanted to show was these are our participating clinics. So this is just an example of a resource list. So they can get this handout of it, but they also have this online version where they can just click to different resource types. So Medicaid or non-Medicaid, we included free resources, which we actually learned about in the process of making this, that King County offers a lot of free mental health resources to kids under age 24. So links right to kind of free mental health counseling as long as it's tele. How we were asked to do our like under Medicaid and non-Medicaid is include both the number as well as if there's individual clinics, the direct numbers to get to those individual clinics, as well as instructions of if they're able to call themselves to schedule an intake, being really clear that they can call to do that. So I am gonna stop sharing at this point because I feel like I've been talking a long time. But that is overall kind of where we are with the project. We are currently in the pilot phase of it. While I don't think any of my research team is here, I did want to acknowledge lots of folks that you all have worked with too. Annie Hong, Adia Abler have been really helpful in creating all of these materials and have been just phenomenal on our research team. So wanted to shout them out. But that's it. Yeah. So any thoughts, questions, would love to try to answer.
Sarah, this is absolutely incredible. Thank you so much for sharing all of the work, and thank you so much for doing all of the work. I think this is such a beautiful example of kind of like really understanding some of the complexities and pressures and dynamics that providers are experiencing and that teens and parents are experiencing, and kind of like finding a path forward. And I think when so much of the conversation, I think, is often like, oh, we just can't do it. Oh, we just can't, or oh, this isn't working, or this isn't working. It's like, okay, well, like, let's figure out how to make it work. And I think this is such a beautiful example of what you have shown is doing that, and such huge potential for impact. So, no, just wanted to share, I think, the most gratitude for this work. I think it is really, really beautifully done.
Thank
I echo that, at least out from EDC. I was just curious. So the website at this point is very focused on those. I mean, obviously you have broader resources, but the more direct resources are Washington State. I'm just trying. So we worked on a project a couple years back of video to support parents after a child's suicide attempt. And we kind of went on a similar journey on the parent side of sort of what there was, which is not much. So anyway, I'll share this talk if it's recorded or the slides with my colleagues. I'm just wondering if there's a connection we can make to sort of learn from each other's work and sort of amplify some of the great resources that you've put together from the
Yeah, I would
study.
love to. And I can throw my email in the chat too. Right now, well, let me not multitask because I'm bad at that. Um, right now we're focused on these 3 clinics in Washington State, and in particular, just because that's kind of the scope of this size project. The parent resources that we have are actually not national. So I'm happy to share those. The reason they're national is just because that is, I don't think we have targeted parent family resources. It seems like that's just a gap overall. So I'm happy to share those. The like parent guardian support groups, those are all national kind of organizations that are doing it. Self-care is really, coping skills for parents, and the here other parent guardian stories again are pulled from like national organizations. So happy to share those resources.
That's great. Yeah, and I'll just throw in the chat. So we work with a partner called what is our partner called? Parents to Parents. They've been working on other videos to support parents whose kids are struggling with substance misuse problems and things like that. So that might be an interesting connect. The video that's featured on the website is pretty long, but it's sort of chapter by chapter, and it talks a lot about, dealing with your own emotions. Again, since there's, the guilt that can
Mhm.
come with, oh, I didn't see it coming. And anyway, so feel free to also include that if you think it's helpful.
Okay. Yep.
And yeah, and I'll loop back with my colleague Julie Goldstein Grummett and see what
Yeah.
connection we can make
We'll
offline.
coordinate.
Yeah,
Great.
awesome.
Thanks.
Thanks.
Great talk. I'm a research coordinator from Beta Cultural Medicine. We're working on implement safety aid in primary care settings for all over Texas. Amazing talk. I also very inspired by the point to have more school support and primary care support, everything collaborating on this. How do you think to facilitate school involvement and primary care, all different settings go together?
Yeah. So far what we found, because we're doing a lot of extra work from our research team and where we're doing the reach outs to see if folks are even open to it. What we've generally found is the schools want to collaborate. PCPs want to collaborate. What we're running into is who is doing the legwork to build the collaboration. So right now, the way we're trying to make that path move forward is just having the clinics implement kind of universally release of information for schools if there's any mental health concerns and just building that into their general clinic flow and paperwork. And that at least allows them to reach out to the school counselor. And each clinic at this point is doing something a little bit different where they can either, if they have a case manager, then that person might be the person that's doing that coordination. If they have IDH, they might be doing it. Sometimes it's the PCP. So that part isn't quite as standardized. But this, from what we've seen so far, they're all on board with wanting to collaborate. And I think in part because the schools feel like they can then lean on the PCPs and the PCPs can lean a little bit on the schools. And that also has a nice mesh of, the PCP can do some med management where the school can't, but they can coordinate and make sure a kid can be seen every week in the school, whereas a primary care office, just feasibly, they're not going to see a kid on a weekly basis. But yeah.
I guess not to piggyback on that, Sarah, what are your thoughts, I guess, around how to involve young people? It sounded like in general, the young people were very interested in having kind of that both support from their school and their PCP and having that kind of release of information or kind of communication or collaboration between those groups. Is there, I guess, and this may differ clinic to clinic given the processes differ, but just wondering, I guess, how young people like the practical elements of a release of information, especially about a kind of protected like that often the young person, at least in our clinic, the young person needs to kind of consent to have their mental health information be shared. And some of the other kind of releases of information are, parents can sign on behalf of. And so I guess I just wasn't sure if that the logistics or kind of details of that, how that part was working for some of the clinics in terms of having the young person actually kind of indicate, yes, I would like to kind of have my mental health information be released,
At this
to
point,
my school
they're
counselor.
part of it. Yeah, they're
Okay.
if they're 13 plus, they're
I
the
think
ones
that feels
would be
important.
consenting to it.
Totally.
And under 13, and the other avenue we've been taking is that universal guidance for parents and how to connect with the school if you're concerned. So it's at this point, we're not forcing anybody to do an ROI. It's opening it up to the conversation, and then
Totally.
the parent for a younger kid could just express concerns to the school. But also, we're not talking about sharing actual physical information. It's more being able to verbally connect. But that's a great point. Yeah. Well, and I know we're about at time, so happy to answer any questions or if anyone wants to connect. I threw my email in the chat. But yeah, thanks for joining. Julianne, is there anything else that you needed to do for this meeting?
Thank you so much. I just plopped in the chat a survey if folks want to leave any feedback for us, helps us know how we're doing. And we will be sending out the recording here for folks to view or share with their colleagues probably sometime next week.
Sounds good. Also, a quick question: is a website like in testing phase, or is currently
It's being
running?
piloted. Yeah, it got user
Okay.
tested. So it's been fully vetted and user tested. It's just now we're piloting it with the clinics and having them actually use it in real time with folks and giving feedback on it. So once that's done, I'm happy to share those results. I just don't have them because we're currently in the middle of it.
Yes, please.
Yeah.
Well, thank you so much. I hope folks have a wonderful rest of your Wednesday. And we'll see you for the next one.